Okay, shall we make a start? We've got a good number of people in the meeting now. So I will just do a very quick introduction. We've got the privilege of got Miss Rennie and Mr. Gane with us today to go through some pearls and pitfalls of HHT, a bit of background about the condition and some top tips for FRCS. Miss Rennie is a consultant rhinologist and anterior skull base surgeon at Imperial, and Mr. Gane is a consultant rhinologist at UCH and the Royal National Ear, Nose and Throat Hospital. And between the two of them, their combined practice is definitely the highest volume management of HHT in the country. So we're very, very lucky to have two such experienced speakers talking to us this evening. For those in the meeting, just to let you know that the meeting is being recorded. We're hoping to publish the video in due course on our BRS YouTube channel. We'll let you know when the recording is available for if people want to refer back to it when they're revising for the FRCS. If we've got time at the end, we'll take some questions. So please do feel free to post any questions as we go along in the chat. And then we'll come back to them at the end. So over to you, Miss Rennie and Mr. Gane. Thank you very much.
Thanks, Talisa. Thank you very much for the introduction. As I mentioned, Simon and I are going to split the talk between us, so we'll be going back and forth between us as we go through. So hopefully we'll keep your attention going through it like that. As I mentioned, we're both trained by Valerie Lund, who has written quite a lot of the ENT papers on HHT. So hopefully we'll be saying the same thing as we go through. And we will give you what we do currently in managing HHT. So if just some questions for the FRCS, because I noted you mentioned it's for the FRCS. So just if you can think about these as we go through, what is HHT and how is it diagnosed? What are the ENT and non-ENT manifestations of HHT? What's the underlying pathophysiology? How are acute nosebleeds managed in HHT? And what are the medical and surgical options available? Hopefully by the end of the session, everybody will know those, as we'll be going through an introduction, the epidemiology, the pathophysiology, our diagnosis and screening, and then the management, medical and surgical. And the tattoo on the patient here is one of my patients, and it's just to demonstrate how much the patients need blood transfusions, because she's got her own blood group posted there. So it's a different level of nosebleed. So it's autosomal dominant. It's 1 in 5,000 patients, and it's 85,000 Europeans. Imperial, we've currently got 200 HHT patients on the books at the moment, but under the ENT service, and more who are under Professor Shovlin at the Hammersmith. In ENT, we see them because of their nosebleeds, and that's how they typically present. There is a risk of GI bleeding and the arteriovenous malformations, 50% with pulmonary, 10% cerebral, 30 to 60% with hepatic, and then a smaller risk of other viscera being involved. We put together with Bhav Patel an ENT flashcard, which is available on the YouTube channel. So if you want to know more about that, I suggest you have a look. The link to it is there. HHT is also known as Osler-Weber-Rendu or Rendu-Weber-Osler. And who were these people? Well, HHT was first discovered in the 1890s, and it was a French physician who saw the skin and mucosal lesions. And then in 1901, there was a Canadian-born physician who saw the GI tract lesions. And then in 1907, an English physician who reported this wasn't a clotting abnormality, but it was an abnormality with the blood vessels themselves. Hence the Osler-Weber-Rendu. Why it wasn't Rendu Osler-Weber in historical order, I don't know, but I've always known it as Osler-Weber-Rendu. And the HHT wasn't actually coined until a bit later in 1909 by an American physician. The diagnosis was a clinical one until the genetics were found, and that was a research group at Duke University who found the genes behind it in 1994 and 96, respectively. And the first international meeting that put the criteria together was in Curacao. And this is a reason to get involved in HHT, because this is where they go for their meetings. So I would suggest going along to an HHT meeting. They pick the best places. This is a Dutch Caribbean island. It has great marine life and lots of beautiful coves there to go and visit. The criteria are what you will be asked for in FRCS, and you can see the diagram on the left. The first one is multiple telangiectasia in the typical locations. You see them on the hands, the finger, and the mucous membranes. The second one is the proven visceral AVMs, typically the lungs, brain, could be spinal or hepatic. And then number 3, what we see them for in ENT, the spontaneous recurrent epistaxis and a first degree family member. We say if you've got 2 of the criteria, it's possible HHT, but if there's 3 or 4, then we give it a definite HHT diagnosis. These are the typical telangiectasia we see here on the mucous membrane, the fingers, and on the lips of these patients. And here is what we see when we look in the nose. So it looks like a little bundle of blood vessels just underneath the surface. So when you breathe in and out of the nose, it dries the mucosa. This can crack and these blood vessels will bleed. And you can imagine if you wanted to go and stick a Mericel, like a piece of cardboard in that nose, you would create quite a lot of trauma and make the situation a lot worse. So HHT, rarely symptomatic in childhood, but most of them have had symptoms by 16 and over 90% by the age of 40. Epistaxis is most common and it varies significantly in severity, and it can influence the quality of life. The telangiectasia are tortuous dilated vessels and really sensitive to touch, and they lack elastin fibers, so they don't vasoconstrict with bleeding. This is Simon's slide, but I'll play it for you here. I really like that one, the nosebleed. Sorry, Simon. I'll let you do your next one. But it was
these are your sides.
This is from one of my patients who sent me how much they bleed with their HHT epistaxis. So I hope nobody's eating at home at the moment, but they have literally sent me pictures of glasses of blood, bathtubs full of blood, and a dinner plate covered in blood from a nosebleed from their severe epistaxis.
And this is the sort of daily reality for a lot of these patients, which is why Kath was saying their impact on quality of life. Actually, weirdly, if you look, their overall life expectancy is not any different to anyone else. And there's some evidence that HHT can be protective for things like cancer. But obviously, if you're bleeding every day from these horrible lesions, these telangiectasia that you can see here scattered around, or something a bit more impressive like the next slide, when you have these horrible cerebral AVMs, then it really has an impact on your life. So AVMs are something that we have to think about as ENT surgeons. They happen about 50% in the lung, about 30%, and they cause a right to left shunt, obviously, and the characteristics of the right to left shunt. So paradoxical embolism, you can get hypertension, hemoptysis, even hemothorax, and also they work as a portal between one side of the circulation and the other. So these patients often have embolic or septic thrombi, strokes, brain abscesses, things like that. They can be really quite dangerous. And we'll talk about the ways that we as ENT surgeons need to take those into account when we're starting to treat them a little bit later. In the liver, the liver, as you all know, is a very sort of flexible organ. It can regenerate. It can take a lot of trouble, and so they're usually asymptomatic. We'll talk about screening in a bit, but if you get enough of them, you can have high flow heart failure, hepatic ischemia, portal hypertension, and basically be put on the list for the liver transplant, which I think both Kath and I have several patients who are on the waiting list at the moment for that. Luckily, the really nasty ones are fairly rare, cerebral AVMs. There was some, we'll talk about the genetics in a little bit as well. There's some thought that perhaps some of the mutations are more likely to have cerebral AVMs than others. But they're pretty horrible when you get them. You're going to get telangiectasia or an AV fistula, and the risk of bleeding is about 0.5% per year. The problem is, we'll talk about the Aruba trial a little bit later on, whether you should go looking for them before they cause trouble.
So this is just to remind you that although the patients are anemic and you think it's due to their nosebleeds, if you get their nosebleeds under control and we still haven't gotten control of their anemia, think about the telangiectasia that can be in the GI tract. And we quite often have to request a GI capsule endoscopy to look at this. And you can pick up the telangiectasia as you go through the duodenum down into the small intestine. Yeah.
It's all very well, but then what do you do about them? Yeah, they can be a real problem to deal with. So Kath mentioned the Kurosawa criteria. The main thing to remember about this is both a blessing and a curse, is that this is an autosomal dominant genetic condition. So you can really clearly map an inheritance pattern. And I always say, if you want to remember the Kurosawa criteria, you just have to remember the name HHT, because hereditary is an old-fashioned word for genetic. The only inheritance pattern that an old-fashioned person would have recognized was autosomal dominant. So you have to have a family, prior first-degree family member. Hemorrhagic, they're bleeding. We're ENT surgeons. What do you see that's going to bleed? The nose, so it's epistaxis. So that's the second criterion. And then the third is telangiectasia. They get telangiectasia, as Kath said. That's one of the third criterion. And then the fourth is they can get telangiectasia, or which are micro AVMs or bigger AVMs, and that's the fourth criterion. So that the whole of the Kurosawa criteria are contained within the name HHT. The genetics is, as Kath said, fairly well worked out. There are two dominant genes, ACVRL1 and the ENG, endoglin gene. If you've been really bad in a past life, you can have a SMAD4 mutation, which gives you not only HHT but also juvenile polyposis and the risk of cancer that goes along with that. So that's a pretty horrible one. Fortunately, I've only seen one patient with that. There are several other genetic loci. Not only some of them are identified genes, which have been identified, but they're a sort of small handful of percentages. And the reason that all these genes are causing this kind of trouble is because of this pathway. So this is the vascular endothelial growth factor pathway. And it's a balance between the SMADs 2 and 3. If you just click, it should hopefully animate. Maybe it hasn't come across with this. Yeah, causing upregulation of VEGF through the transcription of target genes, and then 1, 5, and 8 causing complex with SMAD4, so to cause downregulation of the VEGF. And usually this is in complex balance in the healing process especially. But the problem is that this is driven via BMP9, ALK1, and endoglin. And that's the signaling pathway on the cell surface. And so when those get knocked out or are non-functional, even if you get only one non-functional gene, then you start to get an imbalance in the growth factor secretion, usually during the healing period, which is why we see the lesions, for instance, at the front of the nose rather than at the back of the nose, because that's where the recurrent trauma that Kath was talking about earlier happens. So if you want to understand more, you'll see there's a QR code for all of the papers that are being summarized in this slide.
And just to say that while we look at the Kurosawa criteria now, we can actually get genetic testing for HHT. This was the 2022 update, and we are able to test in the UK when there are 3 of the following current criteria met. One thing to point out is that ENT surgeons currently can't request genetic testing. So it has to be done through a genetic service, but the GP can refer to the patient's local genetic service for this. So if they have 3 of the epistaxis, telangiectasia, visceral AVMs, or family history, so essentially are meeting the Kurosawa criteria, or if they've got one of the personal history of a pulmonary AVM or 2 or more AVMs, or they have severe epistaxis and an AVM or a family history. is all here on the form, and you can have a look at it on the Genomic Laboratory website. But certainly it's worth asking a GP to refer to a genetic service in order to get the HHT gene correct, because if it is a SMAD4 genetic abnormality, there is certain screening criteria that we have to go through with those people.
So we're going to talk a little bit about the management based on these very good papers, the second international guidelines, as well as a lot of work that Kath did with the Rare Diseases Network.
Yeah, so in 2016, I joined Prof. Shovlin at the Vassen Rare Disease Collaborative Network, where we came up with the European management framework for HHT, which just has a few differences to the international one that was published 2 years earlier. One thing for you guys to be aware of is there is a Nature review on HHT that was published on the 9th of January. The paper is there and it's worth having a look at. It gives a really good overview of HHT. When you're sitting in clinic and seeing a patient you think might have HHT, we ask that you go through the following 5 different things with them. So they need to have some advice on how to manage their nosebleeds. You need to be thinking about iron deficiency and anemia and how they're managing that. If you think they've got HHT, we should be screening for pulmonary AVMs. And also I recommend that patients who've got HHT have antibiotic prophylaxis if they're going to see their dentist or if they're having any minor surgical procedure done due to the risk of having septic emboli from those procedures. There's also important information for pregnancy. It's a high risk pregnancy if you've got HHT, and as it's an autosomal dominant condition, we can now refer in the UK for pre-implantation genetic screening for HHT, which would mean the family would go for IVF, and it's well worth letting the patients know about that if they are of reproductive age. How we manage or score the bleeding in HHT is a bit different to your normal nosebleeds. So there's a nosebleed grading scale, which is shown here, where you measure the intensity of bleeding from being nothing to staining a handkerchief, soaking a towel, or filling a bowl. The frequency varies from no bleeds in the last 4 weeks to daily bleeds, and whether they need blood transfusions in the last 4 weeks, whether it's been once or more than once. So this is quite a nice way of getting an idea of the intensity frequency of their nosebleeds. Most of the literature now, however, is using the epistaxis severity score, which is very similar. The first 3 questions are pretty much the same, but here they're asking about, have you sought attention for your nosebleed? Are you anemic? And have you received a red cell transfusion for your nose? And it gives you a score again out of 10, and the severity is the same as the other scoring system, but worth being aware of both of them. This one is the one that's used in most research currently, though. I mentioned screening briefly earlier. We always screen for pulmonary AVMs, and I ask for a high-resolution CT chest. Bubble echocardiography is done more in the mainland Europe rather than the high-resolution CT, and that's usually done 5 yearly after puberty and pre and post pregnancy, as this can change the pulmonary AVMs. We don't currently screen for hepatic AVMs in the UK unless the patient's symptomatic. Cerebral AVMs, we discuss this with the patient. Currently, we're not screening because I think Simon mentioned earlier the Aruba trial, where they looked at treating cerebral AVMs in HHT patients, and actually more patients were dying during that trial than were improving or would have done without treatment. So they cancelled the trial, and we no longer screen, because if you're not going to treat based on screening, do we need to know? And that's a discussion we have with our patients in clinic. For GI and SMAD4, so if you're a SMAD4, and we have a couple of families at Charing Cross with a SMAD4 mutation, they all have annual colonoscopies, as they are at risk of bowel cancer from their polyposis. And just as I mentioned in pregnancy, it's a high-risk pregnancy. think about pre-implantation genetic screening or mention it to your patients. And if the patient has any sudden shortness of breath or hemoptysis, they should go to hospital immediately, as you would assume that the pulmonary AVM has ruptured. When we're treating a pregnant patient with HHT, we assume they have cerebral AVMs if they haven't been screened. And therefore, for obstetric management, we try not to prolong the second stage of labour. So you get involved with the Gane, OBS and Gane team early on. And if the patient is going to consider having an epidural or spinal, they get a spinal MRI around 32 weeks gestation, and they get antibiotic prophylaxis at the time of delivery.
So that's just the management of overall of HHT, and hopefully, if you're seeing HHT patients, you will have a team hematologist or other physician who might be taking this seriously and be able to help you with those kind of things. But when it comes to the ENT surgeon, we really have to think of the management from our point of view in two large groups. So the first is, what do you do on the shop floor in A&E? What should we be teaching our A&E colleagues about it? What are we going to do when we have to deal with this ongoing epistaxis? And these patients are experts. They're only coming to A&E if it's really bad. They deal with their bleeds at home. I mean, you saw those pictures from Kath's patient. They wouldn't have gone to hospital. Anybody else would have already been in A&E for 4 hours with a nosebleed like that. That does not bother them. So you really need to have a good understanding of the ways in which HHT is different in managing both the emergency and the elective stuff. I always say that HHT is the anti-rhinology. Everything that you think you have to do in rhinology, you try not to do in HHT. So the first thing is to not do is no nasal cautery. We don't like nasal cautery. It's especially chemical cautery, causes a lot of tissue damage, which we've talked about the fact that healing's at least part of the pathophysiology here. A lot of our older patients, I think you would agree with this, Kath, they have horrible septal perforations, which cause even more trouble because they've had multiple episodes of cautery, cause more and more damage to the mucosa, to the perichondrium, and to the cartilage, and eventually the septum falls out, and that just makes them bleed even more. So no cautery, and also no Maricells. I hate these things. I hate them anyway, but especially in HHT, because you can imagine just shaving off those lesions that Kath showed you earlier with these bits of cardboard. So really try and avoid all of those. We want a nice, soft, lubricated, low pressure pneumatic dressing, and that's your hydrocolloid coated rapid rhino pap. I think everybody really uses these now, but if you can't get the rapid rhino, and I think this would be my first line treatment, this is what I ask for in A&E, is flow seal. The only problem is if it's a very brisk bleed, it might wash your flow seal out. But flow seal or the other hemostatic matrix agents, Surgiflow, things like that, they can be really, really useful in filling up the nose and just tamponading that blood around, accelerating the hemostasis and stopping the bleeding. In addition, they probably already will have tranexamic acid, but they should definitely have tranexamic acid as soon as they hit the doors of A&E. Kath and I both follow a sort of fairly simple algorithm with managing the HHT. We talk about sort of moisturizing. So this is now more elective management. We're going to talk about sort of the first line treatment, moisturizing topical therapies, and then moving down to ablation with or without, or in the same time as oral tranexamic acid. And then when that doesn't work, you progress down to septodermoplasty. If you're clever, you get anti-angiogenic therapies, and if you're desperate, nasal closure. And we'll go through all of those in a little bit more detail. Laying out my approach to the overall algorithm. Screening is done all the time. As Kath has mentioned, you need to be aware of it. I always ask my patients if they've had a recent CT. I actually do use a bubble echo. We've got quite easy access just to minimize the overall exposure to ionizing radiation, but they usually need a follow-up CT anyway, so I can see the argument for just going straight for that. Everyone who presents to you with HHT is going to need some advice on iron, which we'll go through in a bit, as well as topical moisturizing therapies, and then access to regular ablation. I say ablation here. We tend to use lasers. There are some people who use coablation. I've tried that. I don't find it particularly helpful, and it causes, I think, quite a lot of tissue damage. Whereas the laser is very precise, very pinpoint, and the whole idea is to minimize the killing the stuff that you don't want to kill. So you try to get intravascular coagulation. We use a green laser, which is preferentially absorbed with red light. Talk about with red cells, and you can do that basically as much as you want. And depending on the patient, the evidence is they're going to get at least 3 to 4 months, of benefit, but some of them have years. Oral TXA is great. It's really a wonder drug. It's super safe. We'll talk a bit about that. And then at some point when your ablation doesn't work, you can have a septodermoplasty, which we'll explain in more detail. You can probably have, depending on how it's done, they're only very good for the septum, but you could probably have 2 on each side. They'll buy you about 3 to 4 years. And then when that's no longer working, the recurrent ablation is no longer working, then we'll start talking about the stuff like oral tamoxifen, nasal closure, and hopefully angiogenic therapies. So first of all, so advice on iron. This is baseline for all of the HHT patients. Manage their anemia.
So we make sure each of our patients knows that they need to have a balanced diet, which is rich in iron. We give them an advice sheet on this. Professor Shevlin is particularly good at it, and she has a whole outline on do's and don'ts of what you should and shouldn't eat in HHT, which is fantastic. In cases of anemia, we do give low-dose oral iron. It has fewer side effects and increased compliance. So although the ferrous gluconate that we give to our patients has a lower amount of iron in it, it is actually much better tolerated than ferrous sulfate. And we find that our patients take the ferrous gluconate regularly, whereas with the ferrous sulfonate, they won't take it due to the side effects. They get gastrointestinal upset, they get tarry, sticky stools, and they really dislike taking it. Many of our patients are on regular iron transfusions, which are run through the hematology service local to them, and the GP checks their HB intermittently and will refer them for an iron transfusion when their iron levels are low and the HB is dropping off. Also, a number of patients are blood transfusion dependent, and this in itself creates problems because the more and more blood transfusions you have, the more likely you are to develop antibodies in your blood. And I have a number of patients now with lots of antibodies in their blood, which means getting a blood transfusion for them becomes particularly difficult. And I have to arrange a blood transfusion 3 or 4 days ahead so I can phone Collinbrook to get specially matched blood for them that doesn't have any of the antibodies that they could potentially react to. So if there's any way we can get patients out of needing regular blood transfusions, we're keen to look at how we can help them with that. Just as Simon mentioned earlier, some of the emollients and things patients use regularly in their nose, Vaseline, aqueous BP, the Neilmed nasogel, and even nose oil, which is a sesame oil for in your nose. They're all topical emollients that can help with HHT. The rotating antibiotic creams are liked by a lot of our patients. Some get good benefit from them, some don't. We tend to use them 2 weeks at a time. A small amount the size of a pea in each nostril, morning and evening for 2 weeks, starting with one of the 3 for the first 2 weeks, then the second cream for the weeks 3 and 4, and the final cream for weeks 5 and 6. The idea being if you've got any bacterial infection that's exacerbating your problems, or you've had lots of crusting and infection in the front of the nose, this will clear it and hopefully moisturize the nose at the same time, preventing you getting more bleeding. We get patients to rinse their nose. A lot of them who've bled a lot have thick, hard clot in their nose that they can't shift and is very uncomfortable for them. So using things like saline douching is helpful. Not everyone likes doing this, as some of them find it makes their nose bleed more. So it's very patient dependent, and it's not one fix for all.
Claire Shevlin told me last year that it's the type of mutation, not where the gene that's mutated, but the type of mutation that predicts whether or not you benefit from those rotating creams. So it's a frame shift mutation on the, I still don't understand why that should make a difference, but apparently it does. So some patients get on very well with them, some patients don't. Prophylactic antibiotics. So we talked about this as the baseline, the Vaseline recommendations for antibiotics as with anybody with a heart condition. The dentists are usually pretty good with this. We'll talk a little bit about our anesthetic recommendations in a minute, but basically we should be giving them a bolus dose of, or a stat dose of antibiotics whenever there's any invasive procedures, including dentistry. They should all get nosebleed advice. Kath has invented this amazing thing, which I'm going to steal as soon as we finish this.
Yeah, so we have started giving this out to our patients. Ritika, if she's on the call, helped me devise it. She was doing her academic F2 module with us and has given it to a number of our HHT patients. It's for them to take with them if they're presenting to their district general hospital, because they can't make it to their tertiary referral centre when they've got a massive nosebleed at home. And it just goes through when to refer to ENT, how to manage their epistaxis in the department, and what to give them to go home with afterwards. It's got the contact details of our clinical nurse specialist on there, and it just gives the patient something that they can give the A&E SHO who may never have seen a patient with HHT before, some advice to work on that they have there in front of them. And it'd be great to get more feedback on this before we put it out to everybody. So at the moment it's being trialed at Imperial, but certainly it's something that we want to try and get to all our HHT patients.
That's going to be very useful, because all of our HHT patients will say they never go to A&E anymore because nobody knows what's going on, and they're treated like a normal nosebleed. We're going to talk a little bit about surgical options now. It helps having an anaesthetist who knows what they're doing. We've put together a paper which is in a consideration now, looking at the anesthetic considerations and implications. Basically, they all should have hypertensive anesthesia as tolerated. Make sure that they have induction doses of tranexamic acid and antibiotics, and the rest is fairly straightforward. But it really helps to have an anaesthetist who knows what they're doing with these patients, who tolerates their extremely low hemoglobin, and who trusts the surgeons to be able to control these things. So we talked about ablation very quickly. We talked about a KTP. This is to hopefully cause intravascular blanching, coagulation of the lesions. It can be used to photocoagulate and to ablate the lesions completely, but you're trying to preserve, as I said, as much of the mucosa and the surrounding tissue as possible. So as I said, we use a green laser, a KTP or argon, green, blue. So these hemoglobin obviously is a red substance. Red substances preferentially absorb green light and reflect red light, which is what makes them red. That's why we use a green laser, and you can therefore really direct the energy at the red blood cells, hopefully lysing them intravascularly and helping with control these lesions. That's too small. Yeah, the risks are as you can think. And here you can see a laser. This is our old laser. We're using, that's actually 10. My settings are 4 watts continuous, but 10 to the skin. Although I found that 4 watts is actually pretty useful. As I said, some people are using coblation. I've not found it particularly useful. Kath, have you tried it?
No, I agree. I find coblation causes too much thermal damage, and it's quite a wide area. It can be helpful if you have a really, really large telangiectasia, which is a bit big to deal with by the laser alone. So when you've got one that's more like a little mushroom in the nose rather than a telangiectasia, then the coblator can deal with that. But there's extensive thermal damage around it. And I think the laser's more precise and causes less problems longer term.
Yeah, the whole idea is minimizing tissue damage. There has been a recent move to intralesional sclerotherapy with STS and other lesions. There have been a couple of papers, not particularly big trials, but seem to show that there is some evidence. And again, you can imagine this is focally ablating the lesions that are causing the problems. You would imagine that they can get control. I have to say we've tried it intranasally, and it hasn't been particularly useful. Most of the lesions in the nose are too small for this, but this is one of our cases where he had extensive lip lesions. You can see he's also got extensive tongue lesions, and that's really too big to deal with the laser. And in the old days, he would have been talked about having a wedge resection of that lip, but we were able to do sclerotherapy for him under general anesthetic because it can be extremely painful and has quite a horrible swelling post-operatively and quite a lot of pain, which is difficult to control. But you can see here we've got a really nice result. He does have a little bit of tissue defect there. He smokes, and that's quite a handy place to put the cigarette, apparently. But that's probably why he's got such bad lesions. But generally, I think there may be a place for the use of local sclerotherapy placed into the lesions when they need to. So we've got a AVM and vascular team which have been very helpful in developing this kind of thing. There's a little bit of evidence looking at these various these various treatments. I didn't think this was particularly useful, but the bevacizumab we'll talk about in a little bit. But the time to rebleeding was sort of pretty well controlled. What about IR and interventional radiology and endovascular treatments? They do have a place. The problem is when they're dealing with endovascular lesions in the head and neck, they've probably got a 1% stroke risk, which is something that, given that these patients have a relatively normal life expectancy, they're probably fairly sensibly reluctant to undertake. But there are some lesions which are difficult to get to, which cause a lot of trouble, which can be helpful. Kath, do you use IR at all?
No, very, very rare. I can't think of the last case we used IR for in HHT. Yeah. It's really unlikely that we do it. I know that in some places they've done IR to give sclerotherapy systemically. But the concern with that one is that you can potentially send off your sclerotherapy elsewhere if you've got an AVM, and there have been reports of blindness with it, which I think has always scared me slightly. Whereas the interlesional on the lip looked fantastic, so I thought that was a really nice result.
Yeah, I have had a couple of patients who were sent for IR in other centres, and in some of them it was a lethal event. It's really, it doesn't work. The lesions come back. These are not, one lesion. This is an overall genetic problem that keeps causing trouble. So you're not going to have much success. Tranexamic acid is a bit of a wonder drug. It's a lysine analog discovered in the 60s, actually, and really not used until much later. It's got a role intranasally, and certainly some of our patients. I think you use some intranasal tranexamic as well. Do you?
Yeah, I use a lot of it, actually. Some of the patients love it. Some of them find no benefit at all. So.
Exactly. And that has been looked at in some crossover studies, and it did seem to be effective. But I think it is on a case-by-case basis. Oral tranexamic acid, however, really surprisingly safe. So the way it works is by inhibiting clot breakdown. So you have to have initiated thrombosis first, and that's probably what makes it so safe. But generally, it's an extremely useful way of controlling bleeding. Our patients, most of them really love it. It's very useful just to use PRN for a bad bleed, or if they're going somewhere, they're on a flight, something like that, they can take it. But eventually, most of them start taking it for sort of fairly regularly, which always makes me slightly nervous. But if you look at the literature, the contraindications are only arterial thrombosis or a recent VTE. So even a previous venous thromboembolus is it's not a contraindication. There are other things that you might want to consider: atrial fibrillation, thrombophilia, and procoagulant tendencies. You might want to think about whether or not they're going to have the TXA. We were not even going to talk about the nightmares of managing AF in HHT patients because, as you can imagine, even though Claire Chauvelin says that anticoagulation doesn't affect their bleeding, it really, really does in some of them, and it can be quite a problem. So that's where we are in sort of the the algorithm now. And we're going to then move on to what happens when that doesn't work. What are you going to do next?
Yeah, so I've got a nice video, which I hope will play for you, of a septodermoplasty, which we did just a month ago now. Gulid, one of my registrars, has put together this video. So in a septodermoplasty, what we're looking to do is to remove the mucosa, and the mucosa only from the nasal septum. And what you want to do is basically a really bad septoplasty. You don't want to remove the mucoperichondrium. So you want to leave that thin, fine layer covering the septum, but take the mucosa off the top of it. So you want to make a really nice bed that a skin graft will stay on top of. The idea being that a skin graft is much thicker, and even if you've got telangiectasia on your skin, you have an epithelium there that doesn't bleed. So you see all these patients with telangiectasia on their faces and on their fingers, which don't bleed. However, in their nose, they get lots of epistaxis. So if we can have skin with some keratin in it, covering the nasal lining, then they get less nosebleeds. We take a skin graft. This is from the patient's thigh. I use a dermatome to take it. This is Guled, my registrar, taking that split skin graft and spreading it out on the mesher so that we can mesh the graft in order to prevent it having a hematoma underneath it. And then we can put it into the nasal cavity. We put a non-stick dressing like Telfar on the leg, and we cover it in bupivacaine before we put a dressing on it. And it tends to be that the leg is the most painful bit for the patient after this surgery. They complain about the leg dressing, not anything to do with their nose or their nosebleeds. I usually tell them to take the leg dressing off in the shower at 2 weeks after the surgery and get it soaking wet and peel it off. And then they can usually leave it dry at this stage. This is just showing that meshed graft that we've taken out of the nose. And now what we do is we place it on a gelinet in order to have something against it when you're putting it in the nasal cavity. Because if you can imagine trying to get just the skin graft on its own into the nasal cavity, it all flops on top of itself. Whereas when you have it against a piece of gelinet, it gives it some rigidity, so you're able to slide it into the nose, get the skin graft against the septum, and then be able to peel out the gelinet very carefully without removing the whole skin graft, which has been a challenge to many of my trainees. And there have been a number of skin grafts that have gone back out and gone back in again. But as you can see, Gulid does very well with this one. We get the skin graft in, you flatten it out across the septum. You can see the gelinet sitting on top of it. You spread it out. And when I'm clearing the mucosa from the septum, we go from the floor of the nose up to the top of the septum and just behind the head of the middle turbinate. I don't tend to go further back than that with a septodermoplasty, as they don't generally tend to have telangiectasia that bleed further back. This is some Tisiel just going in at the front underneath the graft to hold it in place at the very front edge there, and to allow you to peel that gelinet upwards and backwards and take it out of the nose, leaving the skin graft intact and against the septum. So this is that gelinet coming off the skin graft with the skin graft underneath it, skin graft on the septum, and the gelinet being lifted off. It really is quite fiddly to do this, and it takes a while to get used to it. But you can see it's lifting really nicely there, showing the skin graft left across the septum, where it should heal nicely and form a really nice layer of skin, preventing any nasal bleeding there. You'll see what it looks like at the end in a second. Yeah, so this is well-positioned skin graft, nicely meshed, and just making sure the top edge of it is completely tucked into the top and not rotated on itself, as it tends to want to pull out when you're taking out that gelinet dressing. I then put nasopore packing in on top of it to prevent it lifting off. And I tend to cut my nasopore lengthways and horizontally to put it in as little pieces that I pack up against it. I don't know if you also use nasopore against it, Simon, but we certainly find it quite useful, and it hasn't caused any problems so far.
Spongistan.
Yeah.
But yes, same deal.
Same principle. Yeah. And
So
then I
it's in,
see them back in clinic at 2 weeks. And in the meantime, I just get them to use some saline drops on top of the nasal pore, and I give them some nasal cream. This was the patient who we saw last week in clinic, and you can see the skin graft is taking nicely.
nice.
We've removed all the packing material. We don't suction away all of it and take the skin graft off, but the patient already says they feel a lot better and hasn't bled from that side of the nose. So fingers crossed it works well for them. And we have had some excellent results from it. This is what it typically looks like further down the line. You can see the whiter area, which is the skin graft. This one you can see is beginning to shrink backwards, and you wonder if there is some telangiectasia just developing at the front of it. And this is one of the main problems we see with a septodermoplasty over time, is it does tend to shrink, and therefore you do get telangiectasia developing around the edges of it. You can go back and laser those. Or I know Simon's been back and done a repeat septodermoplasty. I certainly wouldn't do it more than twice, because I think you wouldn't get very good tissue healing at that stage. So you're looking towards a Young's procedure at that stage. This is a patient that Simon and I share. We've both met her many times in clinic. She has horrendous nosebleeds, but will not have a Young's procedure. She's been introduced to other patients of mine who've had Young's procedures and gotten well with it, but it's not something she was prepared to consider. We made her a nasal obturator to see how she'd get on with it. An obturator essentially is just a plug that goes in the nose. We make a mold first, which is the yellow bit on the left, and then we make the pinkish plug that she can have in her nose. It's got a little bar that sits across the columella to stop them inhaling either side of their plug, and then they can take it in and out as they need. We often give these to patients who are thinking about doing a Young's procedure on, just so that they can get used to using it and the sensation of having a blocked nose all the time. You've got to remember, in the patients we're considering this in, their nose is mostly blocked all the time anyway, as it's usually full of blood and clot. So they're not really ever really breathing properly through their nose.
So I'm aware that we've got 10 minutes left, well, 9 minutes left. So just quickly, both Kath and I find oral tamoxifen to be extremely helpful. This is a partial estrogen receptor agonist and antagonist, often used in post breast cancer treatment. In the early days, the Royal National used a lot of estrogen, which had a lot of side effects, and tamoxifen has a small trial which shows some improvement, and certainly we found it quite useful for a lot of the patients. There are some side effects, mainly flushing, endometrial hypertrophy in women, erectile dysfunction in men, but I think it is testament to the efficacy of the treatment that a lot of our patients, even if they've been on it for a long time, will want to stay on it despite those horrible side effects.
I agree, Simon. We still have patients who've been on tamoxifen 10 years post starting it, so they're very keen to stay on it, and they have great results with it. So
yeah, and we talked a bit about that endometrial hypertrophy or hyperplasia can be a real problem for the gynecologists, but not for us. Talk briefly about our other medical options, thalidomide and bevacizumab. Thalidomide can be quite effective in our hands. Unfortunately, they almost all get a peripheral neuropathy, which can be quite debilitating. So I think Kath and I, having tried quite a few of our patients on thalidomide, have now, certainly our last one came off it last week for that reason. And I think that the same is true for you were saying. So yeah,
I don't have anyone left on it.
Yeah. And there are some new thalidomides that might be useful, but they're not available yet. Finally, the last ditch surgical procedure is the famous modified Young's. Professor Valerie Lund was always very modest about this. I think it should be called the Lund procedure, not the Young's procedure. Young described a two-flap technique with holes in the bottom and the top, which is a recipe for disaster in HHT. But Kath has some nice photos on undertaking this.
Yeah, so this is an example of a patient post-Young's, and you really can't see that they've had a nasal closure from the outside. Only by looking up inside their nostril can you even tell their nostrils have been closed. And that's quite nice for patients, because nobody else in a room would suspect that they've had it done. One of the most common complications we see with the 3-flap technique is small pinhole perforation, which I've dealt with in the past by freshening the edges and closing it up. Simon's got a really neat technique that he's used for closing them as well, which he'll show you shortly. Prof. Lund wrote up her series of 100 patients in 22 years and showed fantastic results with nasal closure. We published a paper last year saying, is there still a role for nasal closure in HHT, particularly now we have these anti-angiogenic agents available? The difficulty is not every patient is suitable for an anti-angiogenic agent, and many of our HHT patients have multiple comorbidities, making them not suitable. My case series is just 5 cases, but you can get an idea of the type of patients there. They were having monthly blood transfusions, one of them having weekly blood transfusions. And patient number 5 was an interesting one. She didn't really have that much of an issue with her nosebleeds per se, but she had severe pulmonary hypertension and her anemia was worsening that. And her pulmonary hypertension was life-threatening. She was a patient I actually had to put through a discussion group at the Royal Brompton to see if we could get anyone to anesthetize her, and I would have 1 shot at treating her and only 1 shot. So therefore we decided to do a nasal closure on her, and you can see her hemoglobin came up from 79 to 104 and has been sustained at above 100 since the closure, therefore taking some of the pressure off her pulmonary hypertension and the anemia. These shows the hemoglobin concentration post-operatively in the patients that we had, and everybody's has picked up. And we've now done a review of nasal closure in refractory epistaxis, which has just been accepted for publication in Rhinology. So that should be out in the next month. However, nasal closure has been great, but we do have a couple of patients who are bleeding through the back of their nose still, in spite of the closure. The ones I've seen, the bleeding hasn't been as bad as it's been before, but I know Simon has had some issues with this, and he can tell you about his patient.
So the first thing you want to do is to make sure that you have done a proper closure. So this is a closure failure because of a little pinhole that Kath was saying. Obviously, she just freshens the edges and sews it up, and that's fine. But I over-egged it somewhat and did a VY advancement flap, just to get as much meat into that area as possible to make sure that I had a very dense closure. So just a VY advancement down onto the philtrum and then moving that up in there, obviously covering the whole thing with flow seal. They do bleed a lot, suturing it into place, and he got a really nice result and a very nice closure. And I think these little pinhole perforations can be a real pain. If the closure is intact, I've got a handful of patients who still continue to bleed post-closure, and we have been quite successful in using Avastin for them. But if you can't get Avastin, which we now are having troubles getting it, then opening up, dividing flaps, relasering and closing has helped for some of them. We are running out of time. Very, very briefly, there are a number of therapies looked at rebalancing VEGF. Bevacizumab inhibits the activity of VEGF. Thalidomide inhibits its secretion, and a new drug, pazopanib, which is under trial at the moment, inhibits tyrosine kinase. The first improvement of HHT with bevacizumab was noticed almost as accident, but there are some trials looking, open label trials looking at improvements, and you can see the step changes in the hemoglobin there on some of these. Unfortunately, there's basically a lot of case reports on these things, but bevacizumab has been shown to be very effective. It's not the nicest drug in the world. Hypertension, proteinuria, delayed wound healing, infection, VTE, and even deaths in some series, AVMs reported. These are all usually older patients, but it can be a very nasty drug, so you have to be very careful in giving it. Thalidomide, I think my view has definitely changed over the past year from bitter personal experience, but it does seem to work. And we can sort of skip all of that. And then pazopanib it's the new kid on the block, which also seems to have some helpfulness. But again, these are very, very obscure drugs and really should only be dealt with in a center. And that brings me to the last recommendation from the panel earlier on, which was that HHT patients who desire treatment to be referred to ENT surgeons with an HHT expertise for evaluation and management. And that would be Kath.
Or Simon.
Or this person right here.
Yeah. So just to say, there is a wide range of treatment options available. Which treatment depends on the frequency, severity, and each patient responds differently to the treatment. So it's not one fix for all, but involve your colleagues and deal with these as part of an MDT. They're tricky patients to manage, but they are some of the very most rewarding patients to manage as well, because they're so fed up by the time they reach you that they're really happy that somebody's finally taking their nosebleeds seriously. So thank you very much, guys, for listening. I wasn't sure we'd even make it to an hour, Simon. We're talking
Bang
too
on.
much.
Yeah, well, that's never been a problem for either of us, I think.
Thank you so much, Miss Rennie, Mr. Gane. That was really fantastic. I'm sure you could talk for much longer. It's a huge topic to cover. That was really, really useful, and lots of very key stuff for FRCS. If anybody has any questions for Miss Rennie or Mr. Gane, please pop them in the chat. Just to kick things off, you mentioned about the nightmares of managing patients who are unlucky enough to have AF and HHT. If they're having severe and regular nosebleeds, who else would you get involved in their management, and what would you recommend in terms of that risk-benefit management of their bleed versus clot risk?
So I think, Talisa, you know some of the patients that we've had that we actually get cardiology to review as well, because some of them do have a left atrial appendage that you can potentially have closure of the left atrial appendage, which may prevent them needing ongoing treatment with DOACs or any anticoagulation going forward. So it's worth knowing whether there's any reversibility in the AF or anything you can do about it to prevent their need for the anticoagulation. Obviously, hematology have to be on board with whatever you're managing for these patients, but the cardiology input is essential. The FASN guidelines and European Reference Network tells you to continue using your DOACs and in the HHT patients, but what we find most commonly is our patients stop using them themselves because their nosebleeds are so bad that they won't continue taking them, so they're non-compliant. And it's very tricky to manage those patients. I've got one patient who has his own rapid rhinos at home and has been known to pack his nose himself, which I think is quite out there, but he's now stopped taking his rivaroxaban because he couldn't tolerate it any longer. So it's tricky to manage.
Thank you. Gosh, that's amazing, having your own rapid rhinos at home. That's a new level of nosebleeds.
Yeah.
Another question from Guled to Mr. Gane. Which patients would you consider good candidates for STS, and which lesions are best addressed with this?
So we're talking about the direct STS. So I think you were with me, Guled, when we did some of them. So the big juicy lesions are sort of things that are almost AVMs on their own, and certainly in my hands. The papers have described doing the lesions in the nose. So the lesions come in nasal lesions come in two parts. So you get the sort of more sessile, flat, branching, dilated vessels, and then Kath had a really nice picture of these sort of three-dimensional lumps of tissue, and I think those, if you can access them, are quite useful. I have to say that I've never seen anybody doing STS in the nose themselves for these. This was only done with I only did it with an IR, an interventional radiologist who has experience with injecting STS, but not into these lesions. So there may be a trick to accessing that I don't know. But generally, big chunky lesions, that's the best way of dealing with them. And as you saw, that we've had some really nice results with them.
Thank you very much. And final question. In your experience, is there any difference in the rate of recurrence of the telangiectasia following septodermoplasty, where you're using a meshed versus non-meshed skin graft?
don't think either of us have used a non-mesh skin graft,
Is,
except by mistake.
I think that's from Toby. Was that using the mesher versus fenestrating it manually with the
Was that just
blade?
a blade?
Is that what you meant, Toby? I'm not sure whether you can
Oh, that makes
put that on the
sense.
chat.
The mesh is just
Yeah,
quicker.
sorry, that's what I meant.
Yeah, fenestrating it with a blade just takes you a bit longer. The mesh is very quick to push it through. But I haven't noticed any difference in either.
And the only reason you want to mesh it is because you don't want a hematoma. You don't want blood underneath that graft. Otherwise, it won't take. So you've got to let the blood through in some way. But yeah, I don't think there's any difference. I mean, I've had one that failed, but generally they all take. And if you have 100% success rate, it's very difficult to compare techniques.
Excellent. And that brings us very nicely to a close. Thank you so much, both of you, on behalf of the BRS juniors. Really useful hour. And once we've gone through, we'll just remove some of the patient identifiable parts of the presentation. We'll just double check that with both of you that we've removed everything, and then hopefully we'll be able to publish a recording of the talk in due course. So thank you so much again. Really, really useful. And enjoy the rest of your evening, everybody.
Thank you for inviting us.
Yeah, thanks very much, Talisa. Thank you for hosting. Brilliant.
Pleasure. Take care. Thanks again. Bye.
Bye now.
Bye-bye.